Welcome all of you to this live program on Orthopaedic Principles. Today, our guest of honor is Dr. Jordi Sanchez Ballester from Liverpool, United Kingdom. Dr. Ballester is a consultant orthopedic surgeon based in St. Helens and Knowsley Teaching Hospitals, NHS Trust, respectively. He specializes in foot and ankle surgery, trauma, and knee surgery. Mr. Ballester was trained in Barcelona, Spain, where he's from, and completed his postgraduate studies in London and Manchester. Mr. Ballester is a fellow of the British Orthopaedic Association and a member of the British Orthopaedic Foot and Ankle Society and also the British Association of Surgery Winging. He has many publications in area expertise and is also an honorary senior lecturer at the University of Liverpool. Alongside his surgical and clinical commitments, Mr. Ballester is a member of the examiners panel of the Intercollegiate Specialty Examination in Trauma and Orthopedic Surgery and has been the clinical director of trauma and orthopedic surgery at the St. Helens and Knowsley Teaching Hospitals, NHS Trust from 2013 to 20. If you've noticed, Dr. Ballester has delivered a lecture on a channel which has already reached a huge audience, and today it's my great honor to bring back Mr. Jordi Sanchez Ballester for this wonderful live program. Over to you, Dr. Ballester.
Thank you very much for inviting me again to this great site. So today I'm going to talk about ankle fractures. We probably, everybody knows how to treat ankle fractures because it's a very common fracture. But I'm going to try to give you some new ideas about it. So this is where I work. The objective of this talk will be ankle fractures in general. So we will talk about the lateral, medial, and posterior malleolus, also syndesmotic injuries and ankle fractures in diabetic patients. We will not talk specifically about pilon fractures. So as everything in our specialty, it's important that we take history and we know exactly what has happened and examine the patient. So once we see somebody that is following an injury, a swollen, painful ankle, we very quickly comes into our mind different types of pathologies. We need to make sure that we are quite open in terms of looking at for differential diagnosis, because if we only concentrate in possible typical ankle fracture, we will miss different injuries. So I'm not going to mention them all, but these are on the slide for you to really think about it when somebody comes in the emergency department with inversion or eversion injuries to the ankle. There is as well, I'm sure you're all familiar with these OTTAWA X-ray rules, which is just trying to facilitate the accident and emergency department to rationalize what type of patients need or don't need X-rays. Here in the UK, all the A&E departments, they normally use it. I'm sure that is used in many places in the world. So these are the particular areas that we need to palpate. And if they are painful, then I think recommended an X-ray is the right treatment or the right investigation. So ankle fractures, that's the main thing that we will talk today. And the main two questions that when we see an ankle fracture on the X-ray, we need to think about and try to find out what it is. Is it displaced and it is stable or unstable? I think these are the two main questions when somebody sees an ankle fracture, needs to question himself. Okay, so once based on that, what is undisplaced fracture? So when we have an ankle fracture and we define it as undisplaced, which in fact are 75% of the ankle fractures are undisplaced. So it means that the talus is congruent in the mortise, and although there is sometimes some degree of displacement, or even sometimes we think that there is a bit of rotation of the lateral malleolus, if the talus is congruent in the mortise, this is an undisplaced fracture. And I will explain to you later on why I'm saying that. Talus shift, which if there is a talus shift, that will give you the clue that this is an displaced fracture, and then we will need to think about differently than if it's undisplaced fracture. So what is a Talar shift? I'm sure that we all know, because it's nothing new. It's been very long time ago, the definition of what is a Talar shift. So just for the talk, is no more than 4 millimeters medial clear space, or 2 millimeters more than the superior clear space. So if you have that, there is more than these distances around the talus, then we say that there is a Talar shift. And so that is displaced or undisplaced. The talus is well reduced, is displaced. If it's not, is undisplaced. Moving to the stability of the fracture. So once we see that the fracture is undisplaced, and we need to identify, is it a stable or unstable? So traditionally, any fracture that is usually Weber A or B of the fibula level of the fracture with no medial tenderness or bruising or swelling, that is classified as a stable low energy fracture, and that's the traditionally. In doubt of if it's stable or not, normally we always say treat it as potentially unstable. But these are the basic principles that we always followed. So the second question is, are all patients with medial tenderness and fracture of the lateral malleolus unstable? So the answer is that it's not. They can be stable. And the reason is because the medial tenderness could be due to the fact that the superficial deltoid ligament is the one is damaged, but the deep deltoid ligament is still intact. And that I will explain now why, if the deep ligament is intact, independently of the superficial, even if you are associated with a lateral malleolus fracture, still a stable fracture. So this is is a pictures that I thank my colleague Jim Barry from Blackburn, that is very didactic picture. So it shows that the importance of the stability of the ankle is the deep deltoid ligament, and that has got a check rein function, that if it's intact, it keeps the talus under the mortise, and independently of what happened on the lateral malleolus, the fracture of the ankle is stable. There is some other picture here, so this is a bit more, even more clear. So this rupture of the deep deltoid ligament, it can be clearly on the picture on the left-hand side. If it's ruptured, the talus loses the position in the ankle mortise and follows what the fibula does, and that is unstable. That can happen exactly the same, even if the intact ligament, but the fracture of the medial malleolus occur. The effect is the same. The talus move laterally, and that is displaced, Talar shift, unstable fracture. There is another important biomechanical finding that it tells you that if you have the intact deltoid ligament weight bearing the ankle, what happens is that it tightens the deep deltoid ligament and avoids any displacement of the talus, unless there is a significant fracture of the tibial plafond. But in normal ankle fractures, deep deltoid ligament weight bearing will help. So deep deltoid ligament intact will help to keep the talus in place and not to shift laterally. There is another study biomechanically, which is regarding the rotation of the fibula. As I said at the beginning of the talk, when I show the first picture of the ankle fracture, I said that as long as the talus is in the mortise, you may see a degree of lateral rotation of the fibula, and that is still classified as undisplaced. And the reason for that is because the reality is that although it looks like it's slightly externally rotated in the normal views, in fact, it's not externally rotated. It's the proximal part of the fibula that is internally rotated due to the fact that the intact ligament keeps the position or and the relationship between talus, medial malleolus, and fibula intact. So that's why we can say that is undisplaced. So what we think, looking at the picture on this drawing on the left-hand side of this slide, that the fibula externally rotates, in fact, it doesn't. It doesn't, because the deltoid ligament is intact. So once we have described and we are clear what is a displaced or undisplaced and what is stable or unstable ankle fracture, when we have an undisplaced lateral malleolus fracture without medial tenderness, based on what we discussed so far, that tells me that is stable injury. So because it's a stable injury, these fractures can be treated just basically for pain relief. We give them a type of a ankle brace for pain relief, but not to hold the fracture, because that is a stable injury. So you can create a very easily manufactured ankle stirrup, or you can put an ankle stirrup that is just off the shelf, that fits in the trainer. Patient can fully weight bear, and in 6 weeks this fracture will be healed. And in fact, the follow-up is unnecessary because it will heal, be probably even better than if you have a ligament injury, like an ATFL ligament injury. The fracture will heal. It's very unusual, these fractures, to go to non-union. Then we've got the others that we discussed before, that we are not 100% sure if the fracture is stable, because it's got the lateral malleolus, which is fractured, but there is a swelling on the medial side. So as we said before, even if there is medial tenderness, it could be that the deep deltoid ligament, which is the crucial ligament for the stability, may still be intact. So what do we do with this type of injuries? So what we do is, again, based on the biomechanical studies I explained to you before, if you have that is a fracture of the lateral malleolus and it's undisplaced, but it is a medial tenderness, so we don't know if it may or may not be stable. So the best way is to do an X-ray weight bearing, because as we said before, if you have that the talus in weight bearing position is in the ankle mortise, the deep deltoid ligament, if it's intact, will be tight, and that will reduce it and place it in the right place. If the deltoid ligament is not intact, then a weight bearing will produce a shift and then will tell us that is unstable. So that's the biomechanics behind this principle. So in terms of practical management of these fractures, if there is a patient that has got a fracture of the lateral malleolus with medial tenderness, you can have a day one weight bearing view. That's probably quite reasonable. It's difficult for an orthopedic department to see these patients because they come to you maybe in a week. So normally what we do is in a week time, weight bearing, and if it's been completely satisfactory, there is no displacement, we treat them as a stable fracture. I put here below knee cast. The reason why we put slightly more external support than on the isolated lateral malleolus is because if there is medial swelling and tenderness, is, I think, from the patient point of view of pain relief, it's better to put them in a plaster, or you can put them in a boot. Doesn't really need to be in a below knee plaster, but I think a bit more support than the lateral malleolus is intact, and again, in 5 weeks should be healed with no consequence, because it is stable fracture. If alternatively a fracture that initially it was like this picture showing here, initially was lateral malleolus fractured with medial tenderness but undisplaced, if you weight bear and produce a displacement, that tells us that there is instability, and therefore most likely an open reduction internal fixation will be recommended. So now we're going to talk about displaced and unstable fractures. We've talked before about stables and undisplaced fractures, and now we're moving to the next group. So if you have an unstable fracture, obviously I said before that if there is a gap and there is displace, it should really be treated surgically. But I think it's important to mention the patient selection. Not everybody that has got an unstable displaced fracture needs surgery. You need to look at the patient status of the skin, the comorbidities, is many other issues that age, mobility level, etc. But in principle, all unstable fractures better treated with internal fixation. Obviously, open fractures, multiple injuries are more advised to be treated surgically. It is important that in ankle fractures, the soft tissue envelope has to be really very, very good, and with not too much swelling or blistering, because otherwise the surgery will be increased with a high risk of wound complications. So usually, as traditionally we always say, we either fix it day one or we wait perhaps a week to make sure that everything is right and the wrinkles appears on the ankle skin. So how are we going to fix these fractures? Again, most of what I'm going to talk is been talked in many occasions. I'm just going to talk a bit more about the posterior malleolus, which is a topic that has been recently quite a hot topic in the ankle fractures management. So I will talk about individually each part of the ankle, how we fix them. So we're starting with the lateral malleolus. Again, this is not new. We all know that 1/3 tubular plate is most of the time sufficient. If we put a lacquer screw, I think it's better, it's stronger. In cases of significant comminution with very osteoporotic bone, perhaps a locking anatomical plate will be better, but in most of the circumstances, 1/3 tubular plate with lacquer screw will be more than enough. Moving to the medial malleolus, usually they always associated, well, not always, but usually associated to some other fractures. It's very unusual to find them in isolation. Certainly, if you find only medial malleolus fracture, will be very important to assess proximally in the fibula to make sure that we don't have a Mason-F type of injury. But concentrating on the medial malleolus, we normally advise to fix it because there is an increased risk of symptomatic non-union. I realize that there's been some studies now that it shows that if it's fully undisplaced, the results are quite satisfactory without fixing, but traditionally we always advise to fix them. So these are the type of level of a fracture. We normally fix it with 2 screws, partially threaded with washer. Certainly the level A, which is just a bit of a Volscian fracture, we don't normally recommend to fix it. But level B and C are the ones that we normally recommend to fix it with 2 screws, with washers, and usually you get good compression. In occasions, I'm sure you've seen to fix it with tension band wiring. I'm not a very big fanatic of tension band wiring because normally tension band wiring, you need to have a very clear transverse fractures that produce compression to work. And in many occasions, that is not the case in this medial malleolus fractures, but is another option. So certainly, again, I mentioned here that think if isolated for the high fibula syndesmotic injury, because very unusual to find an isolated medial malleolus fracture. So these are the type of fixation, as I mentioned before, just with a compression of screw, better too, if you can, to avoid rotation and the tension band wiring. On the types D, which is usually quite vertical, is the SAT injury, the one that is a supination adduction type of injury. And I find that the vertical fractures is very difficult to get exactly the 90 degrees compression with only screws. It can be done, as it is been demonstrated in this fracture, but if the position of the screw is not exactly 100% 90 degrees to the fracture line, what happens is that when you compress, it shears it a bit and it doesn't really hold the reduction anatomical. And I normally prefer to put a buttress plate, which is shown here on the picture. So once you position the plate against the fracture, it buttresses it and reduces it anatomically, and it seems, in my hands, seems to be easier than putting screws in isolation. Moving to the syndesmotic injuries, again, I'm not going to say anything very new. We know that all these type C fractures, I think is no point thinking if it is or it is not stable at the level of syndesmosis. All type C fractures in my books are unstable, so you need to fix the syndesmosis, otherwise you will create some instability in the ankle. So how do we fix the syndesmosis? Traditionally, it is a position screw, it's not a compression screw, and you can use one screw or two screws. Normally is 1.5 centimeters above the ankle joint, and we'll need to keep them for about 8 weeks non-weight bearing. And the removal of the screw is controversial. If the screw wants to be removed, the best thing would be to remove it at 12 weeks. I don't normally remove them. There's been some studies that shows that if it breaks weight bearing, the ankle is slightly more mobile and with better results than if it doesn't break. So the breaking the screw, if you decide not to remove them, is not really a clinical consequence to that. So it's good to just have a good discussion with the patient, that you put a syndesmotic screw and discuss the options. If they're very, very keen to have them removed, then we'll remove them, but they need to go back to theatre. Otherwise, we can leave them alone. In most of my patients, when you discuss that option, they decide to leave it alone. There is as well the option to treat the syndesmotic injuries with tight ropes. Usually, if you use a tight rope, you either use one screw and a tight rope or two tight ropes. And again, I think they're it's a very good technique, and I don't think they've got any advantage to the screw. Only advantage is that it is more anatomically, the rigidity in the syndesmosis is less than the screws. So even if you weight bear, nothing will break. It will look better in the X-ray, and there will be good mobility, or the mobility that is required in the syndesmotic area. But both techniques are acceptable. So moving to the posterior malleolus, traditionally we always have been taught that if you have less than 25% of the posterior malleolus affected, there is no need to fixing it. But I think the review of the new literature and some studies have shown that the size of the malleoli is not really the important thing, because anyway, most of the part of the posterior malleolus is extra-articular, is more in relation to what happened with the posterior malleolus and the stability of the syndesmosis if the posterior malleolus is not well reduced, because the posterior tibial fibular ligament is attached into this part of the posterior malleolus. Therefore, if the malleolus is displaced superiorly, then it can produce some degree of laxity and therefore instability in the syndesmotic joint. If not fixed, there is a high risk of non-union. Number one, as I said before, syndesmotic instability, and then an increased risk of osteoarthritis. Traditionally, before all these big talks and big press about the posterior malleolus, we followed this classification, but that classification was not very much linked to management. It was a good way to describe the type of fractures of the posterior malleolus. In 2016, in BOFAS, the British Orthopaedic Foot and Ankle Society meeting, it was a consensus that if we had a posterior malleolus fracture in any type of ankle fracture, CT scan had to be done to assess how it was, and if it was more than 2 millimeters displacement, then required fixation irrespectively on the size of the fragment. And the advice was to be fixed through posterior lateral approach, based on the fact that if you put a screw from the front, it's very difficult, number one, to make sure the tip of the screw holds this little fragment, and number two, even if it holds it, how strong will be the compression? It doesn't really make sense biomechanically to fix this fracture from the front if the little fragment is at the back. So it was a consensus that the posterior lateral approach would be the recommended approach. And normally we use it as a buttress plate. Once you buttress it again, the fracture reduces well, and it stabilizes the syndesmosis. So following this meeting in 2016, in Aintree, especially Lyndon Mason had a big interest in this type of fractures, and he did a lot of work together with Andy Molloy, which is another colleague in Aintree, which they classify these fractures based on what management would be in each of these different types. So if you look at here, there is a type 1, which is a very thin sleeve of fracture of the posterior malleolus. Type 2A is quite big chunk of the posterior lateral side. Type B is if there is as well an associated with a posterior medial side, and the type 3 is nearly a pilon. It's not a pilon, but it's nearly a pilon fracture, which is a big chunk of the posterior malleolus. So the type, this is the same thing, just put it on a 3D scan, but this shows exactly the same type of fractures that I described before with the drawings, and it just for you to understand exactly with the 3D how they look like. Then this is again based on Lyndon Mason, what sort of treatment is applied for each one of them, which if is a type 1 with a very little sleeve of bone at the back, probably fixation of the fracture is not required. So fixation of the fibula as usual, together with a syndesmotic fixation with the screw or tension band, the tie rope will be sufficient. If we move to the 2A, the 2A is probably the most common, and that is the one that we will normally fix with the posterior lateral approach with a buttress plate, and again fix the lateral malleolus as usual. We need to think that even if with that we improve the syndesmotic stability because we fix it from behind, and also we fix the fibula. Keep in mind that perhaps 50% of patients, they may have as well some degree of instability in the front, and they may open. And I think it's important to assess the syndesmotic with the hook test. And if it opens, despite the fact it's got a posterior tibial plate, screws through the syndesmotic will be advisable. The type 2B is the one that you can treat it all through the posterior medial approach, which is just lifting off the tibialis posterior close to the medial malleolus, or you can have a combined posterior medial and posterior lateral for each of the fragments. And the big chunk, which is a type 3, which is practically simple pilon fracture, then is recommended to just use it through the posterior medial approach. So this classification is very helpful in terms of how we fix these fractures. So just to show you some evidence that the results of fixing the posterior malleolus in these complex fractures give a better outcome, is this injury journal, April 2021, that is looking at a group of patients with a posterior malleolus fix and the ones without fixation, which showing higher scores on the fixed group, statistically significant. Obviously, the outcome is worse as bigger is the fragment. That tells you that is a higher energy injury. The thing that as well identified this paper is that although the results are better if we fix the posterior malleolus, there is a higher risk to have a removal of metalwork when we fix the posterior malleolus compared to the group that we did or they didn't fix the posterior malleolus, and it's 15 to 6.2%. So that's something to take into account. But certainly, in my experience, since we've been fixing the posterior malleolus and we have been following these principles, the outcomes on ankle fractures from our point of view is much better. Then just very, very briefly, I talk about the ankle fractures in diabetics, which in a way, the decision to operate or non-operate is generally the same as general ankle fracture management. But the only thing that we need to take into account into diabetes is the possibility of the neuropathy. And I think it's more important the neuropathy than the vasculopathy. Although we always worried about the wound healing, I think I don't see that much as a problem if the skin is satisfactory. The wound healing happens quite well, but this is the neuropathy that makes that we need to fix all these ankles with much more rigidity. And I think in diabetic patient with a neuropathy, if you have a lateral malleolus fracture, it's probably a good indication to put a locking anatomical lateral plate because it's stronger, and put more screws through the syndesmotic to build the construction very rigid. And certainly I would extend the period of non-weight bearing of 2 to 3 times than compared to the non-diabetics to avoid failure of the fixation. And that's the talk about the ankle fractures. I hope you enjoyed it.
Thank you, Dr. Ballester, for that amazing presentation.
Thank you.
Dr. Ballester, you can stop sharing actually.
Okay.
A couple of questions from our side.
Okay.
Now, when do you actually repair the deltoid ligament? Now, you mentioned about the possibility of a deltoid ligament with this Talar shift. But how do you decide based on X-rays and clinical examination that you need to repair the deltoid ligament?
Usually, I don't repair it. although more and more we're repairing it now, if you have a significant dislocation of the talus with a very big gap medially, even if when we fix the lateral malleolus or posterior malleolus, everything looks fine, I probably have a quite low threshold to repair the medial deltoid ligament with a Mitex sutures. Also, I will repair it if we see that we reduce everything and it doesn't really reduce well the talus, which means that maybe the medial ligament is all folded in the gutter. So if I need to explore it and remove it, then I will repair it as well. But in general, if it's not significant displacement of the talus, I fix the lateral malleolus, whatever needs to be done, and everything looks satisfactory, I don't normally do anything. But in these two occasions that I explained, yes, I do repair them.
Thank you, Dr. Ballester, for that. And when you talk about classification, now you've not mentioned about it, but just for an exam, someone who's writing the exam, he wants to know what is the classification, what do the examiner expect from the student regarding the classification? The log Hansen, the Weber, there are so many around, and the problem with log Hansen that the inter-observer reliability is still very low.
Yeah, I don't think for the exam, the log Hansen classification is required. If you know it well, I think you can mention it, but any candidate that mentions log Hansen classification needs to be 100% sure he knows it well, because otherwise can make a mess of it. I think based for the exam, certainly I think for the routine work, if you know the Webers A, B, and C, and what we described at this particular talk, I think it's more than enough. And I think for the studies, it's good to mention the log Hansen because it's good way to classify different injuries. But for the exam and even for normal daily work, we don't normally use it.
Thank you, Dr. Ballester. Just one last question before we end up this session. Now, what do you think are the indications for use of a hindfoot nail in an ankle fracture, especially in elderly patients? I've been into Barcelona, interestingly, and there a lot of surgeons are doing a hindfoot nail in very elderly patients. For example, those are 90s who you don't want to get them back to the OT once again.
Yes. I don't use them. I don't use them. And the reason is if a 90 years old is got a normal skin and the bones don't look too bad and is active, I'll fix it as normal. If you have a patient that is demented or it doesn't walk, or you do a different, or for different reasons, comorbidities, is a patient that you think is not going to do well, either following instructions, etc. Then what we do, and we're trying to write some series, is something simpler than that, which is we put in a statement pin through the tibia anteriorly. So from the tibia goes into the talus, and we go again to the talus and calcaneum. So we hold it there just percutaneously. Once the ankle is well reduced, we keep it there, and you treat it as you would treat an external fixator pin care. And at 12 weeks, we remove it. And we've got series of 7 or 8 patients. And when we start doing it, I look at the literature, and there is some other literature to support that. And I think it's less money, less comorbidities, because you need to realize that if you put a hindfoot nail, we're dealing with osteoporotic patients, and if the nail is not 100% in the center, it produces a stress razor in any of the points that may be close to it, and if it cracks, then it's a big problem for the patient that we're dealing, which is a very poor patient. So I don't use them, but I know that some do, but that's what my practice is.
Thank you, Dr. Ballester. I think that's all the questions that we have for this session. Thank you for yet another brilliant presentation, and we really look forward for more in the future.
Thank you very much. Thank you for inviting me.
Bye-bye.